Good afternoon. Good afternoon, everyone, and welcome to Research Conference. Today, we are delighted to have Dr. Robert Mentz speak to us. He is Assistant Professor of Medicine in the Advanced Heart Failure Program here at Duke, and is also the Director of the Duke University Cooperative Cardiovascular Society. He completed his training in internal medicine at Brigham and his cardiology fellowship here at Duke. He's a clinical trialist involved in multiple ongoing trials designed to inform the care of cardiac patients, and is also the clinical lead for the International Excel trial. He was recently named a Rising Star by the American College of Cardiology, and his most outstanding achievement to date, at least according to the cardiology fellows here, is his receipt of the 2016 Robert M. Califf Mentorship Award from the Research Fellows. So please join me in welcoming Dr. Mentz.
Okay. Thanks again for the opportunity to present today on some of the research that I began as a fellow here and now had the opportunity to work with a number of the fellows on similar areas. I've got a lot of stuff to go through, but hopefully you'll find this informative. Here are some of my disclosures. So by way of outline, what I'd like to talk about some is how to better understand the heart failure patient population as a means to ultimately answer questions that matter to patients and improve clinical outcomes. And much of my focus in our group has really been on looking at comorbidities, lung disease and diabetes, since it's not a patient you're often looking at, but really a patient that has a number of different disease states all at once. Talk about some of the work we've done to try to improve clinical trials through patient engagement, mHealth, patient-reported outcomes, as well as improving clinical trial efficiencies. And then talk about adoption of clinical evidence into practice and some of the struggles there, and really trying to complete the loop of not only performing the trials, understanding the evidence, but actually bringing it into clinical practice. So in terms of background, we're all familiar with the epidemiology of heart failure. So this is a tremendous problem. Roughly 6 million patients in the US have heart failure. That's about half of those have heart failure with preserved ejection fraction and half have reduced ejection fraction. It's about 900,000 new cases of heart failure diagnosed each year. And I think this third point here is a striking statistic. So at the age of 40, the lifetime risk of heart failure is 1 in 5. And with the aging of the population, it's estimated that by 2030, that it'll be upwards of 8 million patients in the US that have heart failure. So this is a huge problem. And I think highlighted here by one of the most commonly cited statistics, so heart failure is the #1 reason that Medicare patients are hospitalized. If you look at the breakdown, so in red is women and blue is men, you can see over time how this has continued to increase. So it's over 1 million hospitalizations each year in the US due to heart failure alone. And when we look at the treatment, so this is a little bit older slide now, but much of this is still in reality how we practice heart failure management. So you can see the first couple steps of this staircase here. So we're treating the risk factors in those patients that are perceived as at risk for heart failure. As they develop reduced ejection fraction or no longer have the normal squeeze of their heart, that's when we add the evidence-based therapies, ACE inhibitors, ARBs, beta blockers. And then a number of things over time you can see focusing on behavioral changes, dietary, sodium restriction, additional revascularization or device-based therapies, adding aldosterone antagonists, historically kind of the third piece of the guideline-directed medical therapy. And then also I'd like to focus on the latter steps here of advanced therapies and then palliative care and hospice care. And I'll conclude with some of the work we've recently completed in that space. So that was up until 2015. Those were the therapies we had. And despite some of these grim statistics on how the heart failure population continues to increase and have poor outcomes, you can see there's been tremendous progress. So this is looking at each of these evidence-based therapies and the percent reduction in mortality over time. So as compared to placebo, we added ACE inhibitors. That's more than a 20% reduction in mortality. Then on top of that, we had beta blockers. You see an additional reduction in mortality. And then most recently, as we'd added mineralocorticoid receptor antagonists or the aldosterone antagonists, now you have an even greater reduction in mortality. So this is striking progress for a very common disease state just over the past 25 years. But despite these changes, if you look, in 2010, 1 in 9 death certificates listed heart failure. And despite tremendous progress, about 50% of patients that have heart failure will be dead within just that 5-year period. And I think this really shows us nicely. This is from a paper that's a little bit older now, but shows how the changes over time, left is men and the right is women. And you can see over the decades how we've made incremental progress in terms of this reduction in mortality. But still, by 5 to 6 years, 50% of these patients are dead. And if you look at the hospitalized cohort, it's even more striking than that. So if you're hospitalized with heart failure, within 2 years, that's the median survival. So it's really striking. So with this context, I'd like to highlight some of the other struggles we've had. So if you look at, this is kind of a seminal article published in New England Journal in the 70s. It looked at what were the therapies we're using to manage acute heart failure. So those patients that are coming into the hospital with a worsening of their heart failure symptoms. Diuretics or water pills, vasodilators, oxygen, in consideration of inotropic agents, or those drugs that help potentially improve the contractility of the heart. And Greg Fonarow presented a nice paper now a couple years back that looked at how are we doing things in the 2007 up until even more recently now. You can see it's exactly the same. We manage acute heart failure pretty much the same as we did in the 70s. And it's not without a lot of studies that have tried to explore this. So you can look here at the history of phase 3 studies in acute heart failure, and DCRI led the vast majority of these. So you have milrinone, actually led to worse outcomes. You have a couple of these other ones, Relaflin, the PROTECT trial. I always pimp the residents on rounds about this agent because I think it's a fascinating agent, but nobody's heard of it because all of these studies were neutral to negative. And then most recently, to highlight the Nassertide study, ASCEND, the largest acute heart failure study, which Duke led. So I think really trying to highlight this is a major issue. Yes, we've made some progress in the chronic heart failure space, but we still have no options in the acute heart failure space and no therapies at all for the heart failure preserved ejection fraction patient, nothing that improves clinical outcomes. So with this background, I'd like to hopefully shift and show some of the work we've done to try to better understand the heart failure patient population and try to improve clinical trial efficiency and potentially patient outcomes. So this is the model that our group has tried to emphasize. So the first piece on the top, you can see, I think we really need to learn about the heart failure patient population. We need to have deeper phenotyping and understand the patients that we're treating. It's not just a heart failure patient. And a lot of the work we've done is looking at lung disease and diabetes as two of the common comorbidities. In terms of the second piece here, really trying to improve clinical trial efficiency, having patients at the center of this. This has been, I think, one of the key pieces that has helped our group of understanding what outcomes matter to patients. It's not just quality of life as we think about it with the KCCQ or these questionnaires, but really trying to develop patient-centered outcomes. Trying to leverage some of the EHR technology, as have been highlighted nicely in some of the recent talks here. Looking at mHealth and where that might be a capacity, but then also shared decision-making and patient-reported outcomes. So with that, then really generating the evidence, and then the piece here is understanding and improving early adoption. So I'm going to discuss 2 new therapies now that have come out and are available in the U.S. just over the past year and a half and are now in the guidelines, Civabradine and Valsartan sacubitril, that have been shown to improve clinical outcomes, but to highlight how challenging it is to actually adopt these into clinical practice in some of our ongoing work to ultimately, hopefully, improve patient outcomes and then repeat this all over again. So the first piece is really, I think, trying to understand the heart failure patient population. So this is a figure from a nice editorial that Nancy, one of our fellows, just wrote of trying to understand the different implications of comorbidities. I think the coolest thing about this is her dad actually drew this picture for our editorial. So really highlighting this Gordian knot of the challenge of this entanglement of all these different comorbidities. It's not just a 65-year-old man with heart failure. He's got lung disease. He's got diabetes. He's got anemia and all these complicated comorbidities as well as the psychosocial aspects of things. So this slide shows the percentage of patients that have these different comorbidities. So ADHERE and OPTIMIZE are 2 of the large acute heart failure registries that Duke has helped lead. You can see about 30% of patients have COPD or emphysema, underlying lung disease. About 30% have underlying renal dysfunction. And upwards of 40, in some data even suggests 50% of heart failure patients have concomitant diabetes. So I think these are 3 of the areas that we've really tried to focus on to better understand these patients so we can hopefully improve outcomes. So why should we bother to target these comorbidities? So as I've hopefully tried to show here, it is a heterogeneous patient population with heart failure. And these comorbidities can often complicate management. And I'll highlight this in the setting of lung disease, where it's increasingly confusing to try to tease out whether it's their lungs or their hearts that's causing the problem. And that's so important as you're trying to figure out management, because often the treatments can actually be at odds with each other. And we've suggested that careful attention to the diagnosis and management of these, and potentially even focusing on their comorbidities rather than their heart failure, may be able to improve the outcomes for their heart failure disease as well. So this is an older slide, which I think nicely highlights how the additive effect of comorbidities results in poor outcomes for heart failure. So on the x-axis, you can see the number of chronic cardiac conditions from 0 upwards of 10. And then on the y-axis is the prevalence or the probability of being hospitalized during that annual period. You can see up to 100%. So as you add each of these comorbidities, it's upwards of 100% of patients. So the black is heart failure hospitalization, the kind of shaded one is cardiovascular on top of that, and then the white are the non-cardiovascular. So by the time you're getting up to 5, 6, 7 comorbidities, and as you see, a lot of these patients have multiple comorbidities, all these patients end up in the hospital. And I think that's the captive window where we can really try to improve their management in order to improve their clinical outcomes. I'm just going to highlight one of the risk models that I think nicely highlights the importance of comorbidities. So this is from Optimize. In the middle of the screen is those key predictors of mortality. On the far right is mortality or morbidity with rehospitalization, and then on the left is things that are predictive in both. And this demonstrates the importance of these comorbidities. So renal function is captured by creatinine, liver disease, also important psychosocial and cognitive aspects in terms of dementia, depression, as well as anemia and lung disease. But at the end of the day, risk stratification only gets you so far. So I borrowed this slide from Felker. He likes this one because he makes fun of me and says that guy actually looks like me. So I'm saying to this patient, great news, I can predict you will live 4.5 months with a p-value of 0.04. I think this is exactly how this isn't what matters to patients, but it's actually, I want to know how can you improve my outcome, what do we need to do with my medicines, and how can we go forward from here? So I'd like to transition and really focus on some of the work we've done to try to understand what are these comorbidities and how do they influence our management and what can we do to improve patients' outcomes. So the first one is really focusing on lung disease. I'm going to focus on lungs in the diabetic situation. So importantly, both heart disease and lung disease have a shared risk factor profile. So smoking is the most common risk factor in both of these disease states. And it can be so challenging to tease out in these patients what is leading to their worsening of symptoms, because dyspnea or shortness of breath is common in both of these. And if you look at lung tests, if the patient gets their lung test and goes to a pulmonologist or a cardiologist, they can be interpreted quite differently. The vast majority of heart failure patients, if you just looked at their lung tests, they're going to demonstrate substantial underlying lung disease, and it could be due to their lungs or it could be due to their heart, just based on the physiology. Importantly, it can be challenging just actually to diagnose these conditions. So the lung hyperinflation or the enlargement of the lungs in the setting of COPD can challenge some of the diagnostic tests, echo and the auscultatory exam as well for these patients. And just to highlight two really challenging situations, one is the beta blocker selectivity. As we look at some of the beta blockers, one of the two medications, carvedilol, actually is not cardioselective, so you can actually have influence on the lungs in these patients, whereas metoprolol can. So we've done some work to try to tease out which of these beta blockers should we be treating our patients with. And the second is actually the underlying therapies for lung disease. Beta agonists, or the inhaled bronchodilators they're using, actually, there's some data to suggest may influence the beta blocker effect. So the different therapies for the two conditions can really be a challenge. And importantly, depending on which specialty care provider they see, they could receive a different therapy, and I'd highlight prednisone as one of them. So if a patient's complaining of worsening shortness of breath and it's felt to be their underlying lung disease, they might be given a steroid, which could actually worsen their fluid overload, worsen their heart failure, and create this vicious cycle of trying to tease out how do we manage these patients. So one of the first analyses we did when I was a fellow was in the Optimize registry to try to understand the burden of COPD in this patient population. So it's about 25-30% of heart failure with reduced ejection fraction that has COPD. Not surprisingly, as I've highlighted, these patients tend to be older and these comorbidities all track together. These patients have lower blood pressure and are less likely to receive some of our evidence-based therapies. Some of that is due, they have more renal dysfunction, so they're less likely to get some of these medications like ACE inhibitors that are related to renal function. But also, we've really tried to understand what happens during the hospital period and how can we try to improve the background therapy in these patients. So this slide shows 3 of the evidence-based therapies, beta blockers on the left, ACE inhibitors, and aldosterone antagonists, or MRAs. And when we looked at when patients are coming to the hospital, what percentage of patients are continued on these medications, discontinued, and then the initiation. And just to summarize this, What we really saw is that in general, patients were on these medications less at the onset. They were more likely to be discontinued during hospitalization, as for the ACE inhibitor in the center of the screen. But also importantly, they were much less likely to be started on these therapies. And I really vision this as a key point. We have a captive audience to start new medications, and we can appropriately monitor them during this hospitalized period. So we're really missing a key time to start some of these important therapies that improve clinical outcomes. The second analysis we did was to try to understand what are these patients' quality of life and their functional status like. So this is from the HF Action trial of exercise training in heart failure. In the setting of a clinical trial with exclusion criteria, you can see the percentage that had COPD is lower, so about 10% compared to the epidemiologic data that suggests it's around 30%. Nonetheless, these patients that did have COPD that were enrolled in this study had substantially worse depression at baseline as captured by the Beck inventory. The KCCQ, so worse baseline quality of life, that's substantially less here. So 69 median versus 61, or just a difference of 5 is what we're often trying to improve in clinical trials with some of our interventions, and that's the kind of clinically meaningful difference. The 6-minute walk and some of these functional status measures, substantially worse in lung disease patients, 50 meters less. So that's more than the benefit we see with cardiac resynchronization therapy and some of these other interventions on the other side of the spectrum. I'll highlight the last one here, looking at peak VO2. So this is an exercise parameter that we'll do, and it often provides important information as we're looking at advanced therapies, transplantation or LVAD, ventricular assist device in these patients. And the median in these patients that have COPD is much lower and actually below the threshold where we start to explore some of these advanced options, which is a struggle as you're looking at treating a heart condition in patients that have mixed heart and lung disease. In the final 2 slides, I just highlight some of the work we've done looking at the beta blocker selectivity issue as well as the bronchodilator or beta agonist issue. So you can see COPD patients do have worse outcomes, but if you try to tease out the cardioselectivity, meaning did they receive carvedilol or metoprolol, this is a summary slide that really, I think, demonstrates that at the end of the day, we should try to get these patients on beta blockers. They're evidence-based, and that regardless of whether it's cardioselective or non, the benefit is there with these therapies. Certainly you need appropriate monitoring. And this, really what we encourage is this needs to be tested in a randomized trial. So these are all observational data trying to provide some of the hypothesis generating information that we need to have the rationale to say we need to do a trial of which therapy is actually best in those with mixed heart and lung disease. And this is the final piece, looking at bronchodilator therapies where the results were similar. If patients need bronchodilators to manage their COPD symptoms, the data do not support withholding those therapies. There have been concerns that for arrhythmia or sudden cardiac death, but that really hasn't been shown in much of the more contemporary data. So kind of closing out the COPD piece here, much of the work we did led us to really feel that we need a clinical trial in this space, so this is ongoing in development now. To transition some on the second key comorbidity that I wanted to talk about was diabetes. I think this is not only increasing in prevalence, but a really important issue that Duke, I think, is going to be playing a central role in terms of understanding how we can improve heart failure and diabetes outcomes. I'm just going to skip ahead a little bit here, highlight an important analysis that Lauren did of trying to understand, so similar to the COPD space, diabetes and heart failure are very common. And this was a nice analysis that tried to look at when patients have heart failure and are newly diagnosed with diabetes, what kind of medications do they receive? And in summary, what Lauren showed was that they're much less likely to be treated with some of the most common recommended therapies, metformin, given concerns related to their renal dysfunction, and they're much more likely to be started on insulin, first line. There's been quite a bit of concern that even if you adjust for baseline characteristics with patients, that insulin and some of these other therapies may be associated with worse outcomes in heart failure. So I think much is needed to understand this population as well, which provided the rationale for our strategically focused network. So this was just recently funded, really trying to understand the diabetes heart failure space. So this is something I'm really excited about. So there'll be a basic project led by Savati Shah and Rob Magera, the training program, so it'll involve fellow involvement throughout the process led by Joe Rogers. Mike Brady and I and Zubin will be working with the clinical project, which I'm going to highlight today. And then Adrian and Adam DeVore are going to be working on this population project of really trying to understand what medications should we be using in heart failure patients, how can we improve physical activity, as well as medication adherence. So our clinical project coming soon this fall will be looking at a randomized trial of a mobile health behavioral interventions in this population, specifically to look at physical activity and medication adherence. And what we're going to be doing is randomizing 200 patients at just several sites. It'll be 2x2 factorial, so all patients will get this Microsoft band, so we'll be able to follow their step count. And importantly, the intervention arm, they'll actually receive feedback on this. So they'll get text messages and alerts in terms of, you walked 4,000 steps yesterday, let's try to increase that by 250 tomorrow. So really trying to encourage them on a daily basis to increase their physical activity. Then the other aspect is using the Duke Pillbox of really trying to understand what medications they're on, why are they on them, and then encouraging improved adherence. So this is something I think will really provide some important insight related to both the physical activity as well as the patient-centered aspect looking at medication adherence. So kind of in the second piece here, what we've tried to do is best understand this patient population, try to incorporate some innovative aspects into clinical trials, such as the diabetes study looking at mobile health technology and patient-centered outcomes. And I'd like to discuss some of the aspects I've been fortunate to be involved in with the Cardiovascular Clinical Trialists Forum. So this is led by Bert Pitt and Fayez Zanad. And it's, I think, a great opportunity that our fellows have been able to get involved in to learn on a yearly basis. We have a meeting in December, and it includes sponsors, a number of different regulatory and industry representatives, and then also the academics throughout the U.S. and worldwide. And it's an important think tank to understand how can we make clinical trials more efficient. And the piece that I think is most exciting is that we've led the working group here to actually publish on these proceedings and best understand and try to move the ball forward in terms of clinical trial development. So the number of the fellows you can see here, the two on the bottom here, so this was the first year. So this is, it's in DC now, and it's at the French embassy since Fayez Zanad is from France. And they made us all wear these berets the entire time. So I'd highlight Caliph here on the bottom with his beret. He was very excited. And this was the first time we all saw him right after, this was a couple years ago now, after he had taken over the role as FDA commissioner. And he had this amazing suit on. He said, oh, this was tailored by Obama's tailor as well, but he still had his sneakers on. So it nicely balanced out his beret. So just to go through a couple of the things that we've discussed. So the first year we really focused on how can we improve heart failure clinical trials in kind of each of the pieces along the way. First, knowing the drug and detailing how do we better understand the pharmacology of acute heart failure, given all of these failed studies. Importantly, incorporating regional differences, understanding how patient characteristics and outcomes can vary so much based on enrolling region and practice pattern, and accounting for comorbidities and really trying to enroll patients that have comorbidities and targeting them. And then we spent a good bit of time emphasizing and trying to put objective measures on how we can better understand which sites are good for which study and which ones we should really target, and how we can encourage them and engage them throughout the entire trial process. And selecting, importantly, appropriate endpoints. Particularly in the heart failure space, where we've struggled to identify HFpEF patient populations and what does that actually mean, as we look at substantial differences in event rates depending on where HFpEF patients were enrolled around the world, and trying to tease out maybe dyspnea relief is not the endpoint we should be using in acute heart failure studies, but what should we use? And we've done some work to try to understand worsening heart failure, which is an increasingly recognized and potentially important endpoint in clinical trials. I'm just going to skip through a couple of these. I wanted to highlight what I think was a really cool study led by one of our fellows, Arun Krishnamurthy, who's finishing up his heart failure year now. So he was really curious about, we have all these exclusion and inclusion criteria in clinical trials. Which ones are actually ruling out patients? So what he and one of the study coordinators did, they looked over a 3-month period at 3 of the studies that we had actively enrolling, and they did tremendous amount of chart review and actually teased out what percentage of patients would be eligible or excluded for each of these clinical trials. And you can see one of them, tactics, was, so these are looking at both inpatient and outpatient trials. Very few, 7 to 20% of all of these patients would be eligible based on the entry criteria. And he went through and explored which criteria were actually leading to greater exclusion. And now we're incorporating this in clinical trials. And I think it's a nice example of something he was really passionate about, and then going through the entire process and now changing how we're making inclusion and exclusion criteria. I think all of you have seen how often what we'll do is we'll take inclusion and exclusion criteria from prior study, then you move it forward and change it around a little bit. But I think this really informs how that's obviously not a good approach and how we can best change just some of these criteria and dramatically, potentially, increase our enrollment. So the final piece, I'd like to talk about how we've started to incorporate some of these lessons learned in understanding the patient population, trying to improve some of the inclusion-exclusion criteria and overall trial design in order to improve clinical research and improve patient outcomes. So the first medication I'd like to talk about is ivabradine. So this is a heart rate lowering medication. It's a very interesting medicine. So it acts on the sinus node or the pacemaker cells of the heart, and it lowers your heart rate without really much in terms of additional side effect profile. So this medication was shown in the SHIFT trial, which was a placebo-controlled randomized trial of several thousand heart failure patients worldwide, with the exception of included no U.S. patients. And the primary endpoint was cardiovascular death and heart failure hospitalization. You can see a dramatic reduction in the primary endpoint, and this was all driven by heart failure hospitalization. So as you saw on the first slide, heart failure hospitalization, tremendous issue, and this medication has been shown to effectively reduce heart failure hospitalization. Despite this, it took several years to get this into the guidelines. Actually, just several weeks ago, this is in the U.S. guidelines. And it took several years to get FDA approval, but it's now been approved for a year. But I'd like to emphasize there are no U.S. data with this drug. So this really provided the rationale for us to move forward with the PRIME-HF trial. So this is something that Adam DeVore and I are leading here with great leadership from Adrian and others to better understand how this medication can be incorporated into clinical practice and the utility in the United States. So this is a 450 patient strategy trial. We have 50 U.S. sites, and we're hoping to have our first patient by the end of this month. And what we're looking at is, so those patients that meet the labeling indication who come in with acute heart failure are stabilized, and then prior to discharge, we're randomizing them to usual care versus a prescription of ivabradine, and then following them for a 6-month period and understanding the uptake of this, as well as important endpoints looking at quality of life, heart rate, and additional background therapy use. Importantly, this is based on similar prior data from the IMPACT-HF study that looked at starting carvedilol, or one of the key evidence-based therapies in heart failure, during hospitalization, when you have a patient that's engaged and understands the complexity of their situation potentially more, and can then follow them from there and try to improve uptake of these medications and improve clinical outcomes. So this is just the flow chart here. So it'll be patients that are hospitalized, stabilized, and then the randomization. What we've really tried to do is to make this a much lower burden both for sites as well as patients. So we have tried to align all the follow-up visits with usual care. So it's recommended in the guidelines to have a follow-up visit at 1 to 2 weeks. So that's what we've done. We have a study-specific visit at 6 weeks, a phone call to look at medication adherence, concomitant medications at 90 days, and then a 6-month visit. And what we've really tried to do is incorporate a number of the innovative aspects that we've learned in a number of these think tanks and otherwise. So our site selection process was something I've been really passionate about, is trying to identify those sites that have not only done well in our prior acute heart failure studies, but those we have a relationship with. So of our 50 sites, many of those are our Duke sites. So those folks that trained at Duke and have now gone elsewhere and done really well in clinical trials, I think this is a critical piece that we can leverage and actually have this relationship with sites. It means so much in terms of, so if site X isn't enrolling, but they trained here at Duke, you can call them on the phone and really hammer on them how important this is. So we've involved that. And in addition, with the CVCT meetings, a number of the investigators from those meetings, these are the folks that are junior faculty that are the ones actually at the bedside enrolling in all these clinical trials. So we've engaged them as the site PIs for many of these studies. Thankfully, we also have appropriate senior leadership as well in many of the sites. In terms of, I've highlighted some of the study-specific testing. How we've tried to really reduce that burden. If you look at the primary SHIFT paper, there are all these requirements for EKGs at a number of different follow-up periods to look for this. But we're balancing that now this is post-marketing, and actually patients can be enrolled based on telemetry, so they don't have to, prior to randomization, to have their EKG, and to try to make the overall process much smoother. Again, we've reduced the study visits and substantially reduced the case report form. So I think this has been a big time commitment early on, but I think hopefully will pay big dividends in the end. So Sarah Marvin and others have, I think, done a really nice job of helping us to guide how we can reduce the case report form length. And often we collect so much information that will never actually be used at follow-up. So we've dramatically reduced the length of how much information we're collecting at baseline and at follow-up, and really tried to make it that information that it really goes by the guiding principles and shows that we have the right patient with the right drug and that we collect the right outcomes. We're incorporating risk-based monitoring, so not doing all these on-site visits, and we have streamlined safety reporting as well. And importantly, we've incorporated a wearable technology aspect that will help us understand how heart rate changes on a more real-time basis and out in kind of usual routine life. And the final piece I'd like to talk about is understanding the adoption of some of these new therapies and some of the studies we have in development. So the second drug that I mentioned earlier, it's called valsartan sacubitril, or Entresto. And what this is it combines an ARB, valsartan, or one of the standard evidence-based therapies, but also has sacubitril with it, which blocks this other pathway that actually leads to breakdown of a lot of the positive substances in the cardiovascular heart failure system. So this medication was shown in the Paradigm trial of over 8,000 patients to have a 20% reduction in mortality compared to enalapril, or our evidence-based therapy at a very high dose. And importantly, I think this slide nicely shows, in comparison to that first slide that I showed, the progression over time. This is really a tremendous new medication in terms of the improvement in clinical outcomes for our heart failure patients. So what we wanted to explore was this chasm in terms of the adoption of therapies in clinical practice. So this is an Institute of Medicine report that highlighted that from the time of the evidence generation, it takes 17 years for adoption of this into clinical practice, which is just really a tremendous amount of time that so many patients could have benefited from this. So as a result of this, Emily and Nancy are really leading this effort to understand the adoption of Entresto, or valsartan sacubitril, into clinical practice. But importantly, a key piece of this is actually understanding the patient perspective on this. So the steps that we're working on with this project, the first one is understanding which outcomes actually matter to patients. So based on a lot of the work Emily has done in the stroke space, we'll be conducting focus groups and smaller group settings to understand, hospitalization may not be the critical piece for you. Maybe it's something called Days Alive and Out of the Hospital, which she developed and discussed some last week related to stroke patients. So what we're going to be doing is understanding through these focus groups in a structured manner, as well as some open text, really kind of what matters to these patients. Exploring this home time endpoint, and what this involves is actually not just saying, how many days alive and out of the hospital, but understanding out of a nursing home and some of these other aspects which have been identified as important for patients. And then actually looking at how much of this medication is being used in clinical practice. So Nancy's led some nice work of understanding and get with the guidelines, the uptake of this medicine just over the past year. So the first piece is really looking at these focus groups of understanding what matters to patients. We'll be beginning that in the upcoming months. And then the third aim, I think, is really exciting, of understanding the uptake of this. I'm not going to share the data because I'm sure we're going to have her present this in the fall as she hopefully presents this at AHA. But really understanding by linking Get With the Guidelines, or this large acute heart failure registry throughout the U.S. with Medicare data, to understand the uptake of this as well as the impact on clinical outcomes and resource utilization. And then finally, I'd like to talk about two studies that we have in development focused on patient-reported outcomes with valsartan sacubitril, as well as understanding whether a shared decision-making approach with patients could potentially improve adherence. So the first of these is really looking at patient-reported outcomes. And what we'll be doing with this is leveraging the PROCOREnet infrastructure and identifying patients that are newly started on Entresto in usual care, as well as a control group. And then, since it often takes some time to actually get them the medication, given the prior auths and things, we'll consent these patients through an electronic consent, similar to what's being done ongoing with Adaptable. So consent these patients and then have an electronic KCCQ, or this quality of life metric, to understand their quality of life at baseline prior to starting the medication, and then at serial time points, to actually see in the real world, as patients are started on this, how does this improve or reduce their symptoms related to their heart failure. And then having a control group. So this is not a randomized study of placebo versus Entresto, but really trying to look at similar patients that are started on Entresto as compared to control, and understanding how symptoms change over time. And this is being developed with some of our patient review boards. So the kind of key different time points in here, So we'll have this baseline period where patients are identified through the clinical data research networks. They'll receive the e-consent process, the baseline mobile health acquisition of their KCCQ, and importantly, we'll also have a call center backup for this, given concerns for those patients that may not have a smartphone or access to that. And then we'll capture their KCCQ or the quality of life metric at follow-up. But then also, given the amazing capacity of PCORnet with the common data model, we'll actually be able to look back and get a better understanding of what was happening to these patients before they were started on this medication as well, to get an understanding of their trajectory and kind of tempo leading up to these changes, to better see how things change then over time. And then the final piece that I wanted to speak about was a study I'm very excited about. It's called PRESTO. So it's looking at shared decision making to try to find the right dose of medications, specifically looking at Entresto in heart failure. And what we'll be doing with this is, so it'll be 1,500 patients, so this will be randomized, placebo-controlled. Patients will all be receiving Entresto, but it'll be the dosing strategy based on usual care, meaning we follow the label, we start you at this dose based on what that says and try to titrate up over 2 to 4 weeks to the highest dose, versus a personalized medicine approach of using an iPad-based technology and a better understanding and having the conversation with patients about the side effects at different doses, the potential benefits at different doses, and trying to identify the key kind of dose or the target dose for them. And it may be that that changes over time. At first, for many of these patients that have only been able to tolerate lower doses, we may be targeting that lower dose, but working with them over time through this shared decision-making approach to try to increase that dose as best we can. So I think really trying to weigh the side effect profile as well as potential benefits, and working with patients throughout this to try to improve their adherence to medications, their quality of life, and then capturing clinical outcomes as well. So as a result of this, I think our expected results are that by actually having a conversation and not just taking this usual approach of very, I think, paternalistic of saying we're going to start you here and get you to this dose, but really by working with patients, we're able to increase adherence, improve their quality of life, and potentially improve clinical outcomes as well. And then in conclusion, because I feel like it's been kind of a whirlwind through some of the work we have ongoing, I wanted to talk about a study that I've been really passionate about. It's called PAL-HF. So this is a grant that Joe Rogers, James Tulsky, and I wrote when I was a fellow. And it was exceedingly ambitious now looking back at it. But this was an NINR-funded study that Brady Granger and others have been so instrumental in bringing to fruition. But it was a randomized trial of a palliative care intervention. It was a single center, so only at Duke. And we enrolled 150 patients just over a couple year span here. And if you look at the enrollment in this study compared to typically what we see in heart failure, so most heart failure sites, about 0.5 patients per site per month. By the time we really kicked things up, we were enrolling 4, 5, 6 patients just at Duke alone per month. And what this is looking at is usual care in a really sick, advanced heart failure population versus in a very aggressive palliative care intervention. And this was led by Gwen Dodson, one of our palliative care nurse experts. And we've now just kind of locked the database and reviewed the data. I wish I could share this, but I think Joe Rogers would kill me because the paper's still in development. But I think this is a really important piece that Duke and DCRI has contributed to the role of palliative care, really adding in this extra layer of support to a very sick heart failure population. And we hope to present this at the Heart Failure Society meeting in the fall. But this has been a tremendous amount of work. It's been a lot of fun. Jerry and a number of others here have been involved in this. I think this is a piece where we've taken a key area where we did not have evidence to say palliative care should be incorporated into clinical practice. We drafted this study, we're able to get the funding, and now conduct this over a relatively short period. And now I think hopefully be able to change guidelines in terms of how we practice advanced care management. So in conclusion, what I've tried to kind of go through here today is some of our work to better understand heart failure patients. I think there have been a number of successes recently in heart failure. If you look at ivabradine and valsartan sacubitril, but we still need therapies for acute heart failure. So I think better understanding these therapies, incorporating behavioral health aspects, as well as mHealth technology, some of these other things, leveraging EHR as we're able to, but then importantly engaging patients throughout the process and understanding how we can best improve outcomes that matter to them, and then kind of repeat the whole cycle again. So with that, thanks for your time, and I'd be happy to entertain questions.
When you went to streamline the activities so that the visits and the tests mostly aligned with usual care, did you find that usual care was pretty consistent? Because in other parts of the talk, of course, not everybody's following the guidelines. How did you, was that in site selection or what, how did you work that out?
So this is a great point. As we were initially developing this, the thought was, oh, we don't need to pay for these visits because it'll be aligned with usual care. And I think you're exactly right. There's still, despite us trying to pick the right sites for this that are potentially have more homogeneity in terms of follow-up schedule, I think there was still a lot of variability. So we are still paying for those follow-up visits to make sure that we do have the data capture. And I think that's where PCORNet and other opportunities where it'll be, really usual care observational data collected through the common data model and otherwise where we'll really be able to leverage some of those aspects. But it's a great question. I think something we've struggled with, initially very optimistically saying, oh, we're just going to be able to align this with usual care, but that there is a lot of variability and that we need to take that into account.
I have a related question. So, it sounds like you've done a lot of work thinking about streamlining trials and really prioritizing areas that need effort. Would you say that there's universal acceptance of that approach in the scientific community, or have you seen pushback? What's the opposing view to that? Is there anything that we'd be losing if we universally adopted that approach?
Yeah, I think it's a good question. I think the buzzwords now are pragmatic trials. You can't really go anywhere without hearing that term, or EHR, data capture. And you and others are very familiar with, as we've started to really dig our teeth into understanding EHR, I think is a good example. How can we use that and leverage that to actually look at outcome acquisition and things? We see how challenging it is. And there's such variability. If you look at just A1C and how that's captured across the different CDRNs within PCORNet, it's a struggle. So I think that there'll probably be some shift, and I think we see this with Adaptable as well, that I think there was a lot of enthusiasm about using the common data model, but I think we're still incorporating safety nets, right? So you're leveraging Medicare, you're leveraging the call center to make sure we're not missing other outcomes. So I think that's the pushback probably a little bit, is that, yeah, there's a lot of excitement about this, but the more we learn about it, the more we realize how challenging it is, and that a lot of it, billing data are that in the end, they're there for billing, and that it may not capture everything that we need in a clinical trial. And I think what I've become interested in is understanding that a lot of it is, so if you have a large patient population with randomization, yeah, there's going to be some noise and you're going to have some outcomes that you may miss, but that a lot of the clinical trial design characteristics can help us to improve the efficiency of trials as long as we're willing to balance some of those challenges and put that at the, keep it in mind and have it with those caveats, but realize that we have to do things differently. Clinical trials are too costly and take too long, and that we really owe it to patients to be able to conduct things a heck of a lot faster. Great. Well, thank you all. Appreciate it.